Greetings, everyone. Today's topic for discussion will be Anchorage in orthodontics. What is Anchorage? Anchorage is the term that is being coined by Alexis Sklanch. It is a nature and degree of resistance to displacement offered by an anatomic unit when used for the purpose of affecting tooth movement, as given by Graeber. In simple terms, that is being put by Profit, it is resistance to unwanted tooth movement. And White and Gardner explained it as site of delivery from which a force is exerted. The classification of anchorage goes on like this. One is according to the anatomic structure, it can be dental, that is involving the teeth and associated structures, it can be skeletal, involving the skeletal structures, and it can be muscular, the anchorage which is derived from the surrounding muscle. And again, skeletal, it can be intraoral as well as extraoral. The site of anchorage, depending upon the site of anchorage, it can be intraoral, that is your teeth, your alveolar bone, and the palatal bone can be the site of the anchorage. Or extraoral, it can be a cervical region, occipital region, parietal region, frontal, and the symphyseal region. The jaws involved can be intramaxillary, that is within the jaws, within the maxillary arch or within the mandibular arch, or it can be intermaxillary, where the mandible takes anchorage from the maxilla and maxilla takes anchorage from the mandible. Depending upon the force application, it can be a simple anchorage, it can be a stationary anchorage, or it can be a reciprocal anchorage. Everything will be discussed in detail. And again, a simple anchorage, as described by Moyers, it can be a single anchorage or a compound or a reinforced anchorage. What are types of anchorage? Again, it's almost the same which is being explained earlier. As it can be a simple anchorage, it can be stationary anchorage, it can be a reciprocal anchorage, it can be intraoral anchorage or extraoral anchorage, it can be a intramaxillary anchorage or intermaxillary anchorage, it can be a multiple anchorage, or it can be a cortical anchorage. And based on the anatomic units used for the anchorage, that is sources from which the anchorage is being taken, it can be intraoral, that is the teeth. This is the most commonly used structure for taking intraoral anchorage. Mostly it is your molars, the first and second molars, that is being used as an anchorage. The next is your alveolar bone, and then the basal bone again can be used as an anchorage unit. Can be a cortical bone or a cortical anchorage, or can be a mini screw or a skeletal anchorage, which is the latest one. And again, an extraoral, it can be cranium, a back of neck, or the facial bones can be used as an anchorage. Muscles can be used as an anchorage, especially your lips and the surrounding muscles. In general, when you take your teeth as an anchorage, there are a lot of consideration should be given to the morphology of the root. It is again the number of roots present. Larger the number of roots, better the anchorage. The size of the root, whether it is a curved one or a straight one, and the shape of the root. The larger the size, better the anchorage. Slender the size, the anchorage will be weak. Shape, again, the triangular one offers a better anchorage, and next is the oval, and the least anchorage is offered by the round one. And then the root surface area, the larger the root surface area, better the anchorage. And after that, the position of the tooth in the arch. Farther the tooth which is being used as an anchorage, better is the anchorage. And then inclination of the tooth. Look at this image. It shows when you want to pull a heavier thing, you have to incline towards the distal aspect. That is, the crown should be inclined distally, the root should be medial. The crown should be tipped distally to reinforce the anchorage. Interdigitation of cusp. A proper digitization, interdigitization of the cusp is necessary for better anchorage. And then contact points. Broader contact points would provide better anchorage. Mesial drift. The mesial drift should be avoided as much as possible to provide a better anchorage. And then ankylosed teeth provides 100% anchorage. Ankylosed teeth and skeletal anchorage are the two important concepts of anchorage, wherein 100% or absolute anchorage is being absolute anchorage is being taken. So the root surface area of the anchor teeth, a larger surface area has a better anchorage compared to the smaller surface area. Multi-rooted teeth is always better as an anchor teeth compared to a single rooted tooth. Longer the root, better is the anchorage compared to the shorter root. A triangular root tooth has a better anchorage compared to the conical root. And then the alveolar bone offers resistance up to a threshold. Here, on the basal bone, such as the hard palate and also the lingual surface of the mandible, can be taken as a anchorage structure. Here in this picture, you can view the Nance palatal arch, which is taken support from the anterior part of the palate, and then the distalization appliance, a pendulum appliance, which takes anchorage from the tooth as well as from the palate. And then cortical bone. Cortical bone basically offers a better anchorage compared to the medullary bone because your cortical bone is more harder and it is more resistant to resorption. So what they do is they'll just tip the tooth in such a way that the root gets divergent towards the cortical bone and the root will be hitting the cortical bone, and this itself will offer the resistance, but due consideration should be given to avoid root resorption as well. Extraoral anchorage is the anchorage which is situated outside the oral cavity. It can be a cervical region where the nape of the neck is used to obtain the anchorage, or it can be a occipital anchorage, or it can be a combination of both. So what is the strategy for anchorage control? First thing, to concentrate the force needed to produce tooth movement where it is desired. It is like whether you are going to get the teeth back, whether you are going to retract the anterior teeth, or you are going to protract the posterior teeth, or it is halfway. You are going to retract and protract. And then you will have to dissipate the reactionary force to as many teeth as possible. Every reaction has an equal and opposite reaction. So when in the opposite reaction side, you have a lot of tooth. So you should include the premolars, molars as well as second molars, so that the pressure gets distributed to all the teeth, thereby the anchorage loss is avoided. Anchorage loss is nothing but when the anchor tooth moves in an undesired fashion. So coming on to simple anchorage. Simple anchorage is a dental anchorage in which the manner and application of force tends to displace or change the axial inclination of the tooth or the teeth that forms the anchorage unit in the plane of space in which force is being applied. In simple terms, any resistance offered to the tipping movement of the teeth is called the simple anchorage. So this is a herein wherein we have to push the teeth out. A simple anchorage is obtained by the use of a palatal plate. Next is the stationary anchorage. Here, the resistance is being offered to the bodily movement. It is a dental anchorage in which the manner and application of force tends to cause a bodily movement of the teeth or a tooth that forms the anchorage unit in the plane of space in which force is being applied. The stationary anchorage is always better than the simple anchorage. So here what happens, the anchored tooth have to be moved completely forward. The anchored tooth have to be moved completely forward in order to provide a desired tooth movement. In other words, the resistance offered to a bodily movement is much better. You can't move a tooth bodily. So the anchorage unit is much stable and the retraction easily occurs. Next is the reciprocal anchorage. It is very simple, where one tooth or one jaw provides the resistance for the movement for the other jaw and vice versa. For example, when you have to close a midline diastema, you can look at this diagram. When you want to close a midline diastema, I'll place an elastic between the two teeth. What happens is that your 1-1 acts as an anchorage unit for 2-1 and 2-1 acts as an anchorage unit for 1-1. Ultimately, both the teeth will come closer together and then the space gets closed. Likewise, when you want to correct a cross bite or a scissor bite, I give an elastics, a cross bite elastics or a scissor bite elastics. Your maxillary jaw will act as an anchorage unit for the mandibular teeth, and the mandibular teeth will act as an anchorage unit for the maxillary teeth. This is called as reciprocal anchorage. And next is intramaxillary anchorage. Intramaxillary anchorage is anchorage in which the resistance units are all situated within the same jaw. For example, when you use a nance palatal arch, or when you take a support from the maxillary molar to retract the maxillary anteriors, then it is called as an intramaxillary anchorage. Intermaxillary anchorage is where the anchorage unit is situated in one jaw or used to affect the tooth movement in the other jaw. As I explained earlier, intermaxillary elastics is nothing but like a class 2, class 3 elastics, where I'm going to push the maxilla forward and mandible backward using a class 3 elastics. So your maxillary teeth will act as an anchorage for the mandible, and mandible teeth acts as an anchorage for maxilla. Also, the forceps appliance or a Herbst appliance or a telescopic appliance that is being used to reposition the mandible forward, such as your fixed functional appliance. Here again, your maxillary jaw will act as an anchorage for the mandible, and mandible acts as an anchorage for the maxilla. Single or primary anchorage. When a single tooth acts as a resistant unit, it is called single or primary anchorage. Most commonly, your molars are used as a single or the primary anchorage when only one molar teeth is used. Or it can be a compound anchorage, more than one teeth. So here, what you can see is, initially I'm going to retract the canine alone back. So I'm going to distalize the canine back. Individual canine retraction is being carried over. And then this canine premolar and molar along with the second molar will act as an unit. So this is, here I'm using second molar, first molar, your second premolar and also canine to retract the anteriors, and this is called as compound anchorage. Reinforced or multiple anchorage. So reinforced or multiple anchorage again can be asked as a short note. So what here it is, reinforced or multiple anchorage is nothing but you can reinforce the already existing anchorage. How you can reinforce? One thing, you can add additional teeth. Like I had said in previous, the compound anchorage, you can include the canine also, and the number of teeth can be increased. You can include the second molars, the number of teeth can be increased. And next is anchorage from extraoral sources, such as your headgear, which is being explained already. The extraoral sources can put in headgear along with the molars, the premolars and second molars. You can also put in headgear so that the extraoral source of anchorage provides reinforce the already existing anchorage. You can use a bite plane or a guide plane, something like a SVED bite plane or an anterior inclined plane can be used. You can use a transpalatal arch or a nance palatal arch to reinforce the anchorage. So again, anchorage, you have to understand tooth anchorage can be used, and then you can have something called as anchorage savers. Anchorage savers is nothing but those which have been used, extraoral sources that have been used to reinforce the anchorage. So it is what these anchorage savers does is they reduce the amount of tooth anchorage necessary to correct the malocclusion. In fact, they avoid the tooth coming forward. So what are the anchorage savers? Your headgear can be used as an anchorage saver. Palatal bar, something like a transpalatal arch, can be used as an anchorage saver. And then lip bumper, wherein your mentalis muscle is hyperactive. In those cases, you can use a lip bumper, which is going to distalize the lower molar, as well as it will avoid the pressure from the lips being exerted on the incisors. Transpalatal arch. It's again a short node. It can be used as a space maintainer as well as a anchorage reinforcer. So normally your transpalatal arch extends from one maxillary molar, one maxillary first molar along the contour of the palate to the molar of the opposite side. So this transpalatal arch, it can be a removable one or it can be fixable. So how this acts as an anchorage reinforcement is basically it avoids rolling of the molar. That is tipping of the molar, mesial tipping of the molar, as well as rolling of the molar along the that is mesiobuccal rotation, mesiopalatal rotation of the molar is being avoided by use of a transpalatal arch. So what it does, it prevents the mesial migration of the upper molar during transition from the second deciduous molar to the second premolar, and it can produce molar rotation and change in the root torque if in case it is necessary. Sometimes your molars will be rotated. You can derotate the molars which is being rotated by using a transpalatal. It stabilizes the molar and also it serves as an anchorage reinforcer. And in cases where you have to intrude the molars, wherein the molar is supraerupted, you can use a anchorage through intrusion of molars. You can use a transpalatal arch. Next is your lower lingual arch. Lower lingual arch is similar to the transpalatal arch, and it is being placed or positioned in the lower teeth extending from your molar along the lingual side. It runs anteriorly along the cingulum of the mandibular anterior teeth. It is mostly indicated in cases of class 1 crowding and also in class 3 patients. Nance palatal button, it is contains a acrylic part as well as a wire component. The wire component extends along the palate towards the anterior aspect. From the molar, it runs towards the anterior aspect and forms a small loop in the anterior region, anterior palatal region, and runs to the opposite molar. And in this anterior palatal region, you keep an acrylic button, just acrylize on the anterior portion, right? Acrylic button. So it is indicated in cases of class 1 crowding case and also to hold the maxillary expansion device achieved by the expansion appliance. It is not indicated or it is contraindicated in case of class 2 maxillary protrusion case. Next, you have SVED's bite plane. SVED's bite plane is nothing but there is an acrylic capping. You have an anterior inclined plane. Along with that, you have an acrylic capping on the anterior region. So what it does, it reinforces the anchorage. So whenever you have a bite plane like this, the anterior teeth is going to be, the lower anterior is going to come and hit the upper, and the incisal capping will prevent this upper from getting proclined. And in cases wherein you actually want proclination, you can just give an anterior inclined bite plane. Again, you can see this anterior inclined bite plane, the mandible is being guided forward. At the same time, the inclination of the palate is going to prevent the mandible from getting glided back. Removable appliances can be used as an anchorage unit. Like in the removable appliance, mostly the intraoral anchorage is being achieved by clasp as well as the base plate. And this can be a intramaxillary, where it is within the same jaw, or intermaxillary. Also, you can use a extraoral anchorage, like an headgear, again as a removable appliance. The headgear can be fixed and removed whenever necessary. So what is the strategy to clinically control the anchorage? First thing, move few teeth at a time, and you include as many teeth as possible in the anchorage unit. And also use appliance that produce very light force. Do not use heavy force. Heavy force is the one which is going to cause the anchorage loss. Marquardt and Burstone, they classified or grouped anchorage into 3. One is that can be classified as maximum, moderate, or minimum anchorage, or a group A, which is otherwise called as maximum anchorage, wherein of the total amount of extraction space, only 1/4 is being contributed by posteriors coming forward. So rest all 3/4 is for the anterior retraction. So, which in other words means at least 1/4 of anchorage loss will happen when you use a conventional anchorage technique. So we'll have to reinforce to avoid all those anchorage losses. Next is group B or moderate anchorage case, in which half of the space is being closed by protraction of the posteriors and half of the space is being closed by retraction of anteriors. And the last one is group C or minimum anchorage, wherein lots of molar protraction is being achieved, or posterior protraction, or almost 3/4 is being achieved, and the space closure is being done by 3/4 of posterior protraction. Posteriors coming forward and 1/4 of anterior being guided backward. Apart from these conventional anchorage technique, the latest technique which is being followed to avoid the anchor loss is the skeletal anchorage. So what we saw in earlier classification, so how much ever we struggle to prevent the anchorage loss, some amount of anchorage loss does occur. So to avoid this, the new technique was developed, which is called as skeletal anchorage technique. So what is the requirement of an orthodontic anchor implant? It should be small, it should be affordable, it should be easy to place, it should be resistant to orthodontic forces, you should be able to load it immediately, it should be usable with familiar orthodontic mechanics, and with the use of temporary anchorage device, it should also be easy to be removed once the work is over. So types of skeletal anchorage. Previously, they used the conventional dental implants for the skeletal anchorage. And nowadays, they have started using a temporary anchorage device for skeletal anchorage. So conventional dental implants can be placed only in retromolar region or in edentulous areas. So this can be troublesome for many patients because one is the severity of surgery. The surgery is going to be extensive, and the during initial healing, there is a discomfort which is present, and difficulty of oral hygiene maintenance is also a problem in these cases. And again, you'll have to give time for osseous integration. Only when the implant, osseointegration of implant occurs, you will be able to load the implant and then retract the teeth which is present anteriorly. Later on, they started using interdental implants. These are like endosseous implants, which are smaller in diameter and they have mechanical retention. The advantage of interdental implant is the placement is very easy. It can be done under local anesthesia and it can bring about all types of tooth movement. The removal is easy with interdental implants. These interdental implants can be a mini implant or a micro implant. The terminology is different, but the appliance is almost same. So mini implant was given by Russo Kanomi in 1997. It is just a simple modified surgical mini screw. So the surgical screw which is being used to fix the place, that was modified, and it's a diameter of about 1.2 millimeter in diameter and length of about 6 millimeter in length. The length was pretty short with mini implant. And then micro implants came into being, and they are most commonly used as a temporary anchorage device. It was given by Park et al. In 2001, and this micro implant is placed in the buccal sulcus region or palatal interdental areas. And it can also be placed in the retromolar region as well as in the buccal shelf. The screw dimensions do differ by depending upon which region you want to use. And this micro implants definitely serve as an excellent tool for many cases. So where all these micro implants or skeletal anchorage device is indicated. One is where patient with multiple missing teeth, making it difficult to engage posteriorly. So normally in conventional anchorage technique, we use the molars. We take support from the molars. We are going to retract the anteriors using support from the molar. Your molar is the anchor teeth. What if the anchor teeth itself is missing? In that cases, your mini implants or micro implants can serve as an excellent tool. Then whenever asymmetrical tooth movement is needed, like in cases where one side allowed to pull only 3 millimeter, other side allowed to pull almost 6 millimeter, micro implant can act as an excellent tool in those cases. To treat borderline cases, we had seen cases where group B anchorage or moderate anchorage, wherein half the tooth has to be retracted, half the the posterior, half the space have to be closed by protraction of posteriors, and half the space have to be closed by retraction of anteriors. In those cases, you can use a mini screw. Maximum anchorage case, especially in uncooperative patient for headgear, a case with severe proclination, and also in cases where difficult tooth movement, such as intrusion of the anteriors or posteriors, or whenever you want to do en masse distalization, you have to completely distalize the whole teeth backward. In those cases, again, you'll have to use, and whenever you want protraction of the posteriors, like Posterior protraction is again a difficult one using elastics. Intraoral elastics, though, can be used, but to control the posterior protraction, your implants are an excellent tool. And then to do orthodontic, like orthodontic treatment in patients who are not willing for surgery, like a severe bimax case or a case in which severe intrusion is needed. All those cases you can plan using a micro implants, though it is not going to be as good as a surgery, but definitely it can be a better alternative for cases, severe skeletal cases. So where this implant can be placed, it is given by limb et al. Can be placed in the maxillary buccal molar area or a mid-palatal region as shown in the figure B, or in the palatal slope area, mostly in the region closer to the first molar, and then it can be placed in the mandibular buccal molar area between the two molars or between molar and premolar. Mandibular canine area, where you will have to protract the molars forward, and then mandibular incisor region for achieving mandibular incisor intrusion. So with this, we come to the end of this class in Anchorage. So all you have to remember is one thing: you have something called as conventional anchorage, where the teeth is being used, or extraoral sources of anchorage can be used, or the additional alternative is a skeletal anchorage. Thank you. Thank you.